Good afternoon, everybody. I really appreciate the opportunity to be here, and I wanted to thank Pamela. She's just left, but she's done a great job organizing this meeting, and Brad for his kind hospitality. I was asked to talk about some of the issues, surgical issues that arise as our exstrophy population ages and gets older. And there's some of the problems that can be predicted. Try it on this side.
Is this Canadian?
No. No, they didn't invent those when I was in Canada.
Yeah.
So bring my laptop.
Yeah, just bring your laptop.
Switch me in here. You confused the.
I think it's, there you go.
This is yours. This is me.
No, we got to mirror it.
I don't see the mouse. There it is. There's a mouse. Just close this window, I think, right? Close this guy. There you go.
It's not mirrored. You got to go to your screen.
There you go.
Right, but you're not going to see it. You're
Okay,
go to
so
your
it's
screen. Where's your programs?
down here.
Where are they?
Down here.
There you go. Down here. We need to go to your.
On this side here. Let's go this side.
Where is it?
Let's take this out of here. Let's go to here.
Mirror your images.
Let's go here. Then
Your
space.
system folders. That's
System preferences.
that's for
all. Huh?
that's yeah. There you go.
The space is where's the space? There's the space. There we go. Let's put this in here. And mirroring is on. Okay.
Arrange. Here, arrange. Mirror.
Okay.
Ah, you're good.
All good to go. Sorry about that. All right. Open. There we go. All right. So I was asked to talk about some of the surgical issues that happen with, it's happening, yeah, with our exstrophy patients as we get older. And I thought, what are the important things for our population? They're continence, maintaining good kidney function so that we don't lose our kidney function as we get older, sexual function, musculoskeletal function, body image, and cosmesis. Of all those, continence is the one key thing that really affects quality of life. And all the studies that were out there, the quality of life of our exstrophy population is quite good. Except the ones that are incontinent and have to constantly be wearing protection and worrying about odor and things like that, that really affects quality of life some way or the other. And to understand how you achieve continence, we have to understand that you need storage and you need an outlet that holds well. And then you need to be able to empty that system, whether you empty it spontaneously or using a catheter, as many of us do. I want to remind you that we as surgeons can tighten the outlet of this bladder, but we can't do a functional outlet like the one the Creator does, which is able to relax when we need to urinate. So what we can create is a fixed resistance, and depending on how dry you want to be, I can make you really, really tight, you won't be able to pee. So the drier you are, the less likely you are to urinate. The looser we make the bladder outlet, the more likely you are to urinate. However, in my experience, most patients prefer to be dry rather than to be able to urinate, because being a bit wet is like being wet. Dry is dry, bone dry, never leak a drop, and never have to worry about it. And that's, I think, important. Spontaneous voiding, if we're going to do a bladder neck reconstruction, is really unlikely in our bladder exstrophy population. So we need to set those reasonable expectations with you, and as we counsel you and consult with you. And that you have to appreciate that 85% of our patients will be on clean intermittent catheterization or some sort of device. And when especially teenagers, when they're wet and we're beginning to talk about this, especially the ones that were able to pee a bit, I tell them, well, you hold urine 23 hours. I mean, the normal person urinates 4 or 5 times a day, and each time it takes them a couple of minutes. So the storage function is really the more important function, because you hold urine 23 hours and 50 minutes of the day, and you pee 10 minutes of the day. So I'd rather win on the 23-hour side of this equation. The only way to be able to have a system that relaxes is a system called the artificial urinary sphincter. And the artificial urinary sphincter was designed, it's like a donut that fits around the urethra or the prostate, and you can pump water in it so it closes the bladder neck, and then when you need to urinate, you pump the water out of it, it opens the outlet again, and can be used to urinate normally. We use it a lot in adult men that had prostate cancer and had their sphincters removed, and it's very successful in that setup. But in any person that had bladder neck surgery, our experience with the sphincter has been 100% erosions and failures. So right now, we don't advocate those or put them in any of our exstrophy patients at all. The current reported rates of continence, spontaneous continence in exstrophy patients ranges anywhere from 40 to 80 minutes, depending on who you read. But I caution you, because when you read those papers, they'll say 1 pad a day or 2 pads a day. So how you define continence, the stricter you are with the definition, the lower the success rate. And in my book, as I said, dryness is not a drop. It's complete dryness. And this is a study from England where they looked at patients that were at least 20 years of follow-up. They had 65 patients and had complete data on 50 of them. And only 1 patient was able to be completely dry and void per urethra. The rest, about 85% of them were using catheters of some sort or the other, and about 15% were still wet. When J.P. Capolicchio was our fellow in Toronto, he's in Montreal now, he looked at some of our results and said, oh, you got everybody dry. And I said, so let's write this paper. It's a great paper to write, 100% continence rate. And I said, nuh-uh, you can't write this paper. What you have to write is about how the journey is to get them dry, because otherwise you haven't taught anybody else anything, and your paper will get rejected. So yes, 43 patients with long-term follow-up, they were all dry. But if you look at them carefully, 26% of them had their bladder neck reconstruction, and 5 of those were able to be dry and continent. But the remainder of the 38 patients had repeat bladder neck reconstructions, and then had augmentation, and then 18 became dry, and then the remaining 19 had their bladder necks closed to finally become dry. Right? So this is not dry, voiding, and functioning normally. That only happens in about 5 of 43 or 8% of the patient population. That's as best as it gets. 90% of the patients will need augmentations and catheterization and repeat bladder neck reconstruction, and about a large proportion will still need to have their bladder necks closed. But the one word of caution as you embark on more surgery in your journey, that none of the repeat bladder neck reconstructions worked. None. And why? It's because if you look at the histology of the bladder neck, when it's had multiple operations on it, there's scarring and there's rigidity and it's fixed. And it's very hard to create a pliable continent tube from something that's fixed and scarred and rigid. So the bottom line in this is that 7% of the patients are able to urinate normally and spontaneously and be dry with their native tissue, and the rest will need some additional form of more complex surgery. And for the patients that are, have had multiple failed procedures, we in Toronto used to get a lot of referrals from around the country and from internationally. Patients that would have had 4 and 5 different operations and still had failures and unable to be dry. We developed a more effective way of closing the bladder and neck, where we elevate the back wall of the bladder and neck, get rid of all the scar area, and then take the bladder augment, the intestine that we're going to use for augmentation, and lay it right on top of it with the Mitrofanov. You can see the Mitrofanov on the in the back there, the appendix. And by doing it that way, we had 100% effective closure in those patients without any fistula or breakdown. We had 3 patients that formed stones and 1 that had stomal stenosis in the Mitrofanov. But for patients that have had 5 and 6 operations and were very scarred, that's a very effective way of doing that. And if you're ever embarking in that as part of future surgery for your children and yourselves, have your surgeon look at that paper, because it describes it very well how to get it completely dry. If you are one that has had the bladder and neck closed, you have to learn, you have to be taught how to drain in an emergency in case your Mitrofanov doesn't work. And the most effective way is to take one of those intravenous angiocath and puncture your bladder. It doesn't hurt it, it just drains it for emergencies. Whenever you have a Mitrofanov, the fuller the bladder gets, the more obstructed the Mitrofanov becomes. It angulates and becomes more difficult to catheterize. So you can, if you don't have a pop-off mechanism where you don't have a leakage mechanism and you allow the system to overfill, you are at risk of rupture. So you need to learn and be taught how to drain yourself in emergencies. How about the long-term complications of augmentation? Well, we know the intestine is designed to absorb and secrete. The lining of it, as you can see in this diagram here, has multiple crypts that increase the surface area to allow it to absorb food. Well, it's not designed to be in urine. And so when it's sitting in urine, it doesn't differentiate and it starts reabsorbing waste products that have been excreted in the urine already. So when we use intestine to build up the bladder, we have to deal with the absorptive issues that happen, such as metabolic acidosis and the increased chlorine in the body, the decrease in the total body potassium, the decrease in the magnesium, and the decrease in the linear growth of the child and its effect on the bones. It weakens the bones because a lot of calcium gets mobilized out to neutralize the acidosis. And also the intestine produces mucus, and the mucus is responsible for more infections and for formation of stones. And then there's a small but real risk of cancer that happens by adding intestine and the chronic irritation that happens in contact with urine. So these are all things that once you have this done, you have a lifelong commitment to maintain it and make sure that it doesn't progress in a way that can hurt you in the end. Most of the absorptive, if you have 2 normal kidneys, the kidneys can handle the acidosis and most of the absorptive issues that have there. But it may not be a bad idea to use supplements. And they're very simple. You can use Tums, which is calcium carbonate. It neutralizes the acidosis very effectively. And if you take one pill 3 times a day with your meals, that'll do it. Vitamin D3 will keep a lot of that calcium in the bones. And potassium citrate, because your total body potassium will be low in addition to vitamin B supplementation, B12 especially. The one other thing that you have to recall is when you have urine mixed with, and you have a bladder made of intestine, that your intestine reabsorbs some of that urine, as we said. So if you're on medications that get excreted by the kidneys, they'll get reabsorbed again and recycled into your bloodstream. And so let's say somebody's on chemotherapy for whatever reason, developed a tumor somewhere. A lot of the chemotherapeutic agent that goes into the reconstructed bladder will go back into the circulation. So the dose of their chemotherapy or the dose of their antibiotic needs to be monitored and adjusted by doing blood levels in order to avoid toxic levels of these medications. Augmentation may affect linear growth of the child and may alter the bone mineral content and cause things like osteoporosis, osteomalacia, rickets. And these are more pronounced in children or patients that are missing one kidney or both kidneys or are in renal failure. Jack Elder, who's one of our colleagues, had done this study looking at the height of children with exstrophy before and after augmentation. So if you look at them at an average age of 5.2 years, their height was in the 35th percentile. At 14.6 years after augmentation, their height dropped to the 20th percentile. And if you contrast that with the group of exstrophy patients that did not get augmented, their height remained in the 30th percentile. So clearly augmentation affects height somehow. We looked at bone mineral density in our patients, and in the children with normal kidney function, 85% had normal biochemistry, and their bone mineral density was within 2 standard deviations. So as long as you continue with your supplements and you watch their blood levels, it seems to be reasonably maintained. Let's talk about the secretory stuff a bit. Mucus, for example. Mucus is, do you know what mucus is made of? It's made of protein and sugar. It's mucopolysaccharide. So it's candy for bugs, right? For bacteria, it's like being on a cruise ship. And if you look at, this is an electron micrograph of mucus. And we took just floating mucus from one of the augments and looked at it under an electron microscope. And you can see all the gram-negative and the gram-positive bacteria that are floating there, all those dark circles. These are all bacteria. They don't want to mess around with our immune system. They don't want to have to fight and sit on the wall and fight with the wall when you introduce them in with the catheters. They just float, sit on the globs of mucus and form biofilms and feed off the protein and sugar that's in the mucus, and then increase in number enough that they overwhelm the defenses, and then they jump to the wall of the bladder and cause the infection. So obviously the best way to deal with this is to wash the mucus out. It's not antibiotics. Also, a lot of you that have augments may have formed bladder stones at some point. The incidence is anywhere from 30 to 50%. And if you take one of those stones and crack them in half, what you'll see inside is a glob of mucus. The mucus acts as a nidus or a nucleus for calcification to form around it and formation of those stones. So again, getting rid and washing that mucus is very critical. And the best advice I can give you is to just do large volume washes. 300 mLs of tap water, you can boil it, let it cool down, put them all in, flush the water, and then suck it all out. And by that, you remove the mucus and get rid of most of the infections and stones. But sometimes, despite that, infections still do happen. We're still there? Oh, what happened? It wants me to start from the beginning, guys. Uh-oh. Uh-oh. It quit, completely quit. Okay. Sorry about that. I thought this was a new modern facility, Brad Kropp. Huh? No. Okay. All right. Okay. Despite doing the washouts and doing all this, infections happen. And so then you start, how do bacteria get access into the system? Well, we introduce them with the instrumentation and with the catheters that we do on a daily basis. But it doesn't matter if we drain them all out completely. So if I'm in a rush to go out and play, or if I'm in a rush because I have to run to a meeting and I catheterize and don't wait until my bladder is completely drained, I've introduced some bacteria and I've left some of this bacteria into the bladder forming a bit of a residual volume in the bladder that allows the bugs to then multiply inside and increase in number. Can anybody guess how fast E. coli can double in the bladder? 20 minutes, exactly. So three log multiplications per hour. So when we hold for 6, 7, so if we drain and we leave a couple of ounces, 3, 4 ounces in the bladder, then over the next 6 hours or 4 to 6 hours until I catheterize again, I've got a large 18 to 20-fold increase in the number of bacteria in the bladder. And then if I do that repeatedly over the course of a day or two, the number of bacteria will be so large that it will overwhelm my defense mechanism and eventually cause me an infection. So it's important that we drain well. And if you have any doubts, because sometimes those bladders aren't very uniform, if you have any doubts, next time you're at your urologist, have them ultrasound your bladder after you catheterize. And you'll know if you're completely drained. If you think you're done draining and you still have some urine by ultrasound, then you'll know that you need to change positions or do some irrigations after. The second thing that causes infections is the bowel that we've added into the system. The bowel produces mucus, which is alkaline, and that reduces the defenses of the bladder and allows bacteria to grow faster in the bladder because it's less bacteriostatic. The mucus itself, we said, is protein and sugar, which is great culture medium for the bacteria. And then if a stone forms or if there's a little foreign body in the form of a suture or something, then that gets colonized and it's very difficult to get rid of. Most infections are easy to treat and get rid of, but sometimes we get the stubborn ones that don't go away. And for those, we use some gentamicin installations. And so after you drain the bladder with a catheter, you put some gentamicin in and you leave it inside until the next catheter. And that's very effective in managing the more resistant bugs, saves you having to go in for intravenous antibiotics. And we've done some work with that showed that when we put it in the bladder, the serum levels don't go up. So it's reasonable that way. The one dangerous complication of augmentation is bladder perforation. And that's the one thing that I'm sure your surgeons have cautioned you against. And it happens because of overdistension of the bladder over time. And Barbara talked about one of my patients that when he started drinking in Ontario, you can drink after age 18 or 19. So the kids obviously drink a lot earlier than that. They go to the parks. And he went to work and then went drinking with his buddies and then had too much to drink, passed out, and never catheterized until 3 o'clock in the morning when he woke up with very severe pain and was, by the time we got him to the operating room, he was in shock and his blood pressure was 50 over nothing. And we got him back, but I tell you, you keep doing that. The reason this happens is you leak infected urine into the peritoneum suddenly, and the toxins and the bacteria in the system cause a collapse of the circulatory system, and it causes the shock. So it's not a simple thing to do. And if, you know, when we do augmentations in the younger children, we know the parents are on them like hawks. But when they become 14 and 15-year-olds between the age of adolescence until they get to 17, 18, 19, when they're a bit more accepting and responsible of it, then we're back safe again. But I encourage my patients to do a home manometry system. So if you put your catheter in, the catheter is the black line in this diagram, and you're lying flat on your back, and you hold the catheter straight up in the air, and you put a ruler right next to the pee hole in girls or at the penoscrotal junction in boys, and you measure the height of the water level against the ruler, 0 being at the base of you get a pressure. And as long as you keep that number below 15, 10 to 15, you have a very safe system that won't rupture. If that number starts to creep up to 20, then you know your pressure is too high, right? Our bowel is designed, bowel handles gas, liquids, and solids, right? But when it's full of fluid all the time, it's constant pressure. And it's the constant pressure when I take my finger off here, if you press on your palm for 10 seconds or so and you move your finger, you get a white spot. A white spot means the capillaries there's no blood flowing in that area. And so if there's no blood flowing into the bowel, into areas of bowel, you create what we call relative ischemia, or areas that don't have any blood flow, and they tear and rupture, and that's what causes most of this. And that's why it's important not to allow the the urine to accumulate in the, or hold for long periods of time, because then you're applying constant pressure against the wall. And with this tension, the walls get very thin. So the least amount of trauma, sports, for example, you need to empty those bladders before sports, because the least amount of trauma, or even a good shake with the water going back and forth, will cause that tear. It's like a water balloon, basically. So does absorptive capacity decrease with time? We see atrophy of the villi, those lines that but in reality, no. The mucus production decreases with time, but the absorption of electrolytes and waste from the urine does not. The issue of neoplasia is, again, another serious issue. And in one study that was published in 2012, where this group constantly did prospective biopsies, routine biopsies in their augmented bladders, they didn't find any neoplastic changes within the first 10 years after augmentation. However, they began to see pre-cancerous lesions after 13 years. So we recommend that after 6, 7, 8 years of an augment, that you have a cystoscopy to look inside the bladder, and then periodically every 1 to 2 years after that to make sure that everything's okay. So in summary, for augmentation, it's still the best option to date. We have to correct the subtle metabolic acidosis, and we talked about some of the supplements. You need to prevent infections, mucus, and stones by the washouts, and then cystoscopy periodically for neoplastic changes. This is a lifelong commitment, so if you don't think your child or yourself is ready for this lifelong commitment, don't embark on it. Wait until that person is ready before we go in. Do I have 5 more minutes, or am I out of time? Good, okay. So I just want to talk a bit about the channels, the catheterizable channels, because we do get issues with them over time, stenosis, leakage, and stomal complications at the skin level against stenosis and prolapse. And the initial description by Paul Mitrofanoff, which really revolutionized our ability to give catheterizable continent catheterizable channels, made it much, much simpler for our children, was to put the stoma in the right lower quadrant, especially in girls because of concerns with pregnancies and how the uterus is going to displace. And he cautioned against putting them in the umbilicus. But I think many of us now put it in the umbilicus. I think cosmetically it looks much, much neater and cleaner. And I like the idea of burying the stoma in the umbilicus so that the mucosa is not exposed to air, so it doesn't dry out. And by doing that, I think it preserves it and protects it from the stenosis. So I think with this as an advance, using appliance for the urinary tract in any of our exstrophy populations is something of the past. I don't think that is something that, unless there's no bowel to use to construct a bladder of, I think the alveolar conduits for children is really something of our experience with Mitrofanoff has been so positive. I mean, I took this picture, 10 years follow-up, and now I've left Toronto. This was a patient of mine in Toronto. And I left Toronto 8, 9 years ago. So this is now 20 years out. And this girl is still in touch with me, and she's doing really well, never had to have a revision. And it's been a very successful thing. This is an older patient that I inherited when I came to California. And she has a prolapse of her mucosa. Her stoma was also placed in the umbilicus, but you can see sometimes the appendiceal mucosa prolapses, and also her channel leaks. So she's constantly having to wear protection over her umbilicus, and she has had so much difficulty when they did her initial repair. She had a massive breakdown, and then at about 20 years of age, they took her latissimus muscle, the side muscle from here, and transposed it to cover her abdominal cavity. So she's so reluctant to have her abdomen opened again because of the negative experience she's had with previous surgeries, that we're trying to tweak this with injections to make her drier, but we haven't been successful yet. But that's certainly one of the issues long-term with Mitrofanoff's. The other issue is here you see the appendix, and it's running along the abdominal wall. I'm afraid to touch this computer so we don't crash this system anymore. But you can see, there we go. There's the appendix here. The stoma's up here, the catheter is going in it. But you can see what happened here. There's an elbow that formed. And this young man had some difficulty catheterizing the Mitrofanov. And so the last thing you want to do if you have difficulties, try and force this. You want to advance it nice and gentle. And if you have resistance, just back off for a few minutes and then maybe use an angled catheter or some different approach, different position. Press on the abdominal wall a bit to change the angle. But pushing harder only results in formation of a pocket or a diverticulum and false passages in the appendix, which result in the need for revision, as you can see in this case, because he's created a 90-degree angle into it. Dr. Canning talked a little bit about the penis and the erections and length, and I'll just cover a few things a few modifications that we've done. This is the classic old approach to closing the penis. It looks reasonably well. The glans is nice and conical, but you can see here there's a space between the penis and the scrotum. Right there, there's a strip of skin that goes unused. And a lot of the older repairs, they used to close the skin on the dorsum of the penis with a midline scar. And that midline scar tethers and causes a lot of tension. So this patient, when I'm pulling on his penis this way, and as soon as I let go, it spanks against his abdominal wall. It's really effectively like a rubber band that spanks against and slaps against the abdominal wall. And so we described a way to change how skin coverage is, for the spadius penis is done, and you can see here the flap is being rotated, and it uses the ventral skin. Now there's a reasonable penoscrotal angle here, and that scrotum is right up against the penis, and then the ventral redundant skin is used to provide coverage on the dorsal side, and it provides a very nice penopubic angle and penoscrotal angle, which looks. There's a longer-term picture of that patient, very relaxed appearance and very nice skin cover for the penis. And we applied that in a patient that came to us. This young man came from Somalia, I think, when I was in Toronto still. He was 15 and never had anything done. And we did the same procedure for him. And again, you can see that there's no tethering dorsally for the skin, and it works well. The Kelly procedure, many of you may have heard of. Justin Kelly is an Australian surgeon that developed a way of detaching the penile crura, the erectile bodies of the penis, from the bones, from the pelvic bones, in order to gain length. And this is a paper that just got published this month in the Journal of Pediatric Urology from our group in California. We took cadavers. We have the willing donor bodies to dissect the penis in them, and also in fresh cadavers to see whether it really made a difference in lengthening the penis. And we couldn't demonstrate that you got additional length. You got additional orientation of the erectile bodies, and you got better at bringing the penis out of the body, but you couldn't lengthen the net effective length of the penis. I think is questionable in this. Doug talked a lot about again, the sexual function, so I'll skip through this. But the bottom line in this is that the majority of females are fertile. 85% of them can have babies without difficulty, and the men are about 55%. But orgasm is normal in both, and ejaculation is normal in about 60% of males in that study. Another, I think, important part of this is how the cosmesis in the female patient, because in the classic approach to closing the bladder exstrophy, the mons pubis is dipped inside like that. You can see here that there's an indentation, just doesn't look normal. And so we described a technique whereby you can rotate flaps from the sides and end up with a normal looking mons pubis with some Z-plasties to take away the tension in the abdominal wall, so that those girls are looking more and more normal. And this is something that can be done later on in life if there's a dense scar there, because the tissue is lying on the sides and has not been used in the primary repairs. Those flaps can always be brought together into the midline to improve the cosmesis of the abdominal wall. The vagina, there are issues with depth because it may be a bit shallow, but prolapse and dyspareunia or painful intercourse is the real issue. And I wanted to share with you this patient, which is a girl that got sent to me at age 4 months. She had a closure at a different institution in California, and they did not do osteotomies. And I feel really strongly about osteotomies, even in the newborn, because the defect that we're dealing with in bladder exstrophy or cloacal exstrophy is a total pelvic defect. There's defect in the skin, fascia, muscles, bones, and pelvic floor. So just closing the bladder doesn't cut it. The whole thing has to be repaired, and closing the bones is part of repairing the defect. And as a result of not closing, the bones are constantly trying to open up, and they opened up, and this girl's symphysis pubis defect was less than 3.5 or 4 centimeters, which is the cutoff where centers that say don't need to do osteotomy, say 4 centimeters, you can bring them together. Not true. I mean, every dehiscence I've dealt with had not had an osteotomy. And because her pelvic floor, the levators, the sling that Dr. Canning was describing, separated so much, she prolapsed her rectum all the way to the outside. We redid her with osteotomies, and she's done very well with, and then again, you can see her mons pubis there is looking normal. So all the MRI studies that we did, I'm getting the signal to the trap door is opening under me, have demonstrated that the levators are abnormal before osteotomies, and they improve significantly after the osteotomies and the correction. So, and even in older children that have not had good results, putting the frame, the external fixator on and cranking it using the Elizarov principle can rebuild the pelvic bones and bring them together quite nicely into the midline. So I'll skip all this. And then finally, delivery, I'd like to reinforce what Dr. Canning says. If you have an augment, it's always an elective C-section, right? And you have to have your urologist there because the reservoir is in front of the uterus and the blood supply of it is in front of the uterus. Emergency C-sections are likely to end in disaster. And I'll stop on that note. Thank you very much.